what is the topic that we are dealing with? And the topic is stress fracture. So first of all comes the etiology in the stress fracture. You see, the etiology is that when there is a overuse of bones. Now this overuse of bones is mainly occupational, and that occupation is usually of that of running, all right, where the running is in occupational necessity, like an athlete, a marathon runner, a patient who is a army trainee, a patient who is a police trainee, all right. So where for the physical examination to get cleared, they have to run very hard. So there is an occupational overuse of the lower limb bones that might result in a fracture because of overuse, not because of the trauma. That is known as stress fracture. That means it is a fracture of the bone when they are put or when they are subjected to stresses, all right. Then comes the clinical features. Now, as far as clinical features are concerned, what you tend to see is there will be obviously a pain, and to some extent there will be a swelling also. Reactionary swelling will happen around the stressful bone sites. But because the fracture originates from the medullary canal, just try to understand, if this is a bone which is divided into outer cortical and inner medullary bone, then the breakdown appears in the inner medullary canal, which is not extended, which has not yet extended all the way up to the level of cortex. So once there is no cortical involvement in the beginning, the X-ray is not going to appear, and so are not going to be the clinical features, like signs of the X-rays are also not going to be there. Signs of the fractures are also not going to be there. So the patient is not going to have any sort of crepitus. There will be no abnormal mobility in the beginning of these fractures. There will be pain and persistent swelling for a long duration of time. Then as far as radiological features, that means X-rays are concerned, so initial X-rays are, it could be normal, that initially there could be no finding on the X-rays because it is a breakdown in the medullary canal, not on the cortical activity. Once there is a cortical involvement or there is a line of the breakage appears in the cortical region, then it could be considered to be a final fracture, which will appear on the X-ray. So late in the course of disease, it might appear on the X-ray, but not initially. And that is the reason why MRI is considered to be the investigation of choice. So as to see the fractures, particularly, or the signs associated with the fractures in the medullary canal, MRI is considered to be the investigation of choice. And finally, the management, treatment. Treatment is actually based on rest. The reason for stress fracture is overuse. You have to make the patient, you have to keep that overuse out of the patient, and rest is the management for the stress fractures. So rest with or without immobilization. That means placement of a slab, placement of a cast. It is all just based on the requirement. Like if there is no cortical involvement directly, then even slab application is not going to help much. But yes, if there is a cortical involvement, then you have to apply a slab along with asking a patient to rest for some duration of time till that fracture heals. So, which is obviously has to be coupled with non-steroidal anti-inflammatory drugs. Okay, so that is the complete protocol for stress fracture. Now, one thing that you should be aware of, that what are the most common sites where these fractures happen. So the most common site for these fracture to happen is, or the stress fracture is most commonly seen in neck of second or third metatarsal. You see, second metatarsal neck is the most common site, but if it is not provided to you in the option, you can go for the third metatarsal neck. That is most common. Metatarsal, because it is going to be the fracture in the lower limb, and that too in that part which is coming directly in contact with the ground. So second and third metatarsals are the most common sites. Second is the distal fibula. And the fractures of the distal fibula, the stress fracture of distal fibula, that is why it is also known by the name of runner fracture. Similarly, the fracture neck of second or third metatarsal is known by the name of march fracture. It is again because of the stress. And finally, the third most common site is the distal tibia. So these stress fracture can also happen in case of distal tibia. So these are the most common sites where these fractures can happen. Fracture neck of second and third metatarsal, the fracture of the distal fibula, or the fracture of the distal tibia. So if we talk about the question again, if we try to correlate what we have learned with the question again, that a 28-year-old police trainee, now you came to know how the etiology is important, came to OPD with a complaint of pain and swelling for the last 1 month. On examination, there was no signs of the fracture. Even the x-rays were found to be normal. What next will you do? Continue training? Obviously not. You came to know that it is a stress fracture, and if you ask a patient to continue management training, then it will result in the worsening of these symptoms. Warm fomentation will further invite inflammation. All right. So if you go for hot fomentation or warm fomentation, it will further invite inflammatory process and it will make the symptoms worse. Then immobilization and non-steroidal anti-inflammatory drugs is considered to be the management for the time being. CT scan, obviously not, because it is a core clinical finding which you have already diagnosed. And what is the requirement now is to make the patient rest with appropriate drugs, with or without immobilization, based upon the requirement. So that is the correct answer for this particular question. All right. So with this, we have already talked about the three means with one of the feature or one of the complication because of overuse of the bone, that is stress fracture. So we have talked about the compartment syndrome, fat embolism syndrome, and stress fracture. Now we are going to talk about a complication which occurs late in the course of disease. All right, or it could be iatrogenic, that means related with the management of that particular disease. But before we talk about that topic or the complication, here is a sample question that how the examiner can frame the kind of the question for that particular topic. A 3-year-old male sustained injury to the elbow for which he was taken to a local practitioner. It is a very common practice that happens particularly in a remote area. He subjected the elbow to repeated massage. So what they do is they massage the limb and then they engulf it in a very tight splint. All right, they immobilize it using a very tight splint. Then they repeat these activities of massaging and splinting for several days. And splinting, 3 months later, he was taken to an orthopedic practitioner. Now, what the parents could have realized that there is a limitation of movement. The limb is getting thinned out. He is not able to use it normally. And there is restriction of the elbow in particular. So they subject the child to an orthopedic surgeon. Now they took a child to an orthopedic practitioner with the stiff elbow and a swelling. His ESR was found to be 48 millimeters of, means orthopedic surgeon, just by looking at the condition and by relating it with the history, he has diagnosed the condition. Now what he has done, he has asked for this ESR to get done, erythrocyte sedimentation rate to get done, because it will decide the management at this particular point of time. And ESR was found to be elevated. The normal upper limit of ESR is 10 millimeter per hour, all right, or the first hour. So what next? So first of all, you have to identify the question and then we will decide what next has to be done. The topic that we are going to talk about is a myositis ossificans. Now first of all, let us understand the heading itself. All right. Myo means muscle. Itis is the inflammatory pathology. Ossificans means ossification. Simple. That means bone formation. So what does it mean now? That the muscles gets inflamed or there is an inflammation of muscles which ultimately will result in ossification. So it is an inflammatory ossification of the muscles. Remember, that is myositis ossificans. Now what you have to remember in this particular topic are, point number 1, history of massage. Now this history of massage is always considered as a hint in your question. It will be provided to you as a hint in the question. And just now what we have seen, that if a child is, or if a broken bone is subjected to repeated massage and splinting, then what happens is that you are rubbing the exposed bone with the muscle. When you are continuously rubbing the bone with the exposed muscle, it will lead to injury to that particular muscle, all right, or the muscle will get frictional injury. Iatrogenic, point number 2 is iatrogenic. That means it is not related to the injury, it is related to the malmanagement or ill management. So the condition is related to the treatment. As you can very clearly see that when you are splinting it, when you are massaging it, when you are rubbing the exposed bone with the muscles, you are inviting some disease or you are about to cause a condition. Then just try to understand, when we progress, imagine this is the exposed bony fragment which is continuously kept frictioned against the muscles because of this massage. It will lead to an injury to the muscles. And when the muscles are getting continuously injured, it will invite inflammation. Once there is an inflammation, it will be converted into a granulation tissue. So there will be a creation of a granulation tissue bed onto the site of inflammatory bed, onto the muscles. And granulation tissue is a naive tissue which could be converted into any based upon the stimulus it is receiving. Here it is receiving the stimulus of bone formation. So this granulation tissue eventually will be converted into a bone, and that is why it is known as heterotopic ossification of muscles. That means the site which should not be ossified normally is now getting converted into a bone. So the point number 3, that is heterotopic ossification of muscles. Now hopefully you have understood that what is the essence of myositis ossificans, that throughout this pathological mechanism, it is the normal muscle which is getting converted into a bone. All right. Now, what is the most common site which is likely to be affected? Elbow, because majority of the time this complication happens in case of supracondylar fracture of the humerus. So elbow is considered to be the most common site. Second is the knee joint. All right. So elbow and knee are considered to be the commonest site to be affected. In case of elbow, it is the brachialis muscle which is most commonly ossified because of this myositis ossificans. Then, as far as X-rays are concerned, although the real essence of or real identification of these X-rays are going to be discussed when we are going to compare it with the tumor, but just try to understand at this point of time. Imagine this is a muscle and this is a myositis ossificans lesion. Now the lesion is having a greater density at the edges. It is having a greater density at the core. The central core is having a lesser density in comparison to the edges. All right. So edges are edges are more dense while the core is less dense, or the core is relatively having lucency while the outer margins are more radiodense. That is the identifying feature of a myositis ossificans lesion. Now, how is it differentiated from a tumor? In case of tumor, what happens? A malignant tumor like osteosarcoma, what happens? That the core is more dense while the outer margins are relatively lytic. This is what happens in case of tumor. So X-rays, the outer lesions are denser in compared to the inner in comparison to the inner core. So this is what we came to know about the X-ray. Now, if the disease is active, for example, the inflammatory process is going on in that particular condition, so the acute phase reactants are going to be elevated. So there will be raised ESR and there will be raised CRP in active lesions when the inflammatory process is going on. All right. And this activity of the lesion will decide the management of this particular condition, that is myositis ossificans. So how is it going to be managed then? The treatment will be based on, you see, if the disease is active, then you have to go for immobilization so that there is no further movement and movement related injury to the bone. Immobilization with non-steroidal anti-inflammatory drugs. All right. You put a limb into a slab and give appropriate non-steroidal anti-inflammatory drugs for these inflammatory process to get subsided. Once there is inactivity in the lesion, that means ESR or CRP is found to be normal in an established myositis ossificans. So in case of inactive lesion or latent lesion, in case the lesions are latent where there will be normal ESR or CRP, you have to go for surgical excision. All right. Then you can plan for surgical excision of that particular lesion. In that case, you have to remove it. So hopefully everything is clear related to this topic, that is myositis ossificans. And now we can relate it with the question also that was provided in the form of a sample. Like 3-year-old male child